You're sitting in your favorite chair, reading, watching television, having a conversation. 20 minutes pass, maybe 30, and then it starts. Your foot goes numb. Sometimes it tingles first. Sometimes it just goes quiet, like it isn't fully there anymore. You shift. You stand up. You shake it out. And within a minute or two, it comes back. If you've mentioned this to anyone, you've probably heard the same explanation every time. You're cutting off your circulation. You're sitting on it wrong. It's just your posture. I want to tell you, as directly as I can, that explanation is almost certainly wrong. What's actually happening when your foot goes numb in a chair has very little to do with blood flow. It has everything to do with a nerve, and depending on where that nerve is being affected, the cause could be something happening right at your knee, or something happening much higher up in your lower spine, that the chair is simply revealing rather than causing. Today, I'm going to show you the real mechanism, the two most common locations it can be coming from, and a simple way to tell the difference between something that's harmless and something that deserves a proper evaluation. I want to tell you about a patient I'll call Eleanor. She was 68. For years, she'd noticed her left foot going numb whenever she sat for any real length of time in her armchair, in the car, at church. She'd always assumed it was circulation like everyone had told her, and she'd developed a habit of shifting position every 15 minutes or so to keep the blood moving. It helped a little. It never fully went away. What nobody had ever asked Eleanor, not in any appointment, not in any conversation about it, was how she actually sat. Because Eleanor crossed her legs, almost always the same way, left over right, every single time she sat down, without ever thinking about it. That habit, it turned out, was the entire story. Not her circulation. Not her age. A nerve in a very specific place being pressed on in exactly the same spot, the same way, thousands of times over years. Stay with me, because the location of your numbness and the position you're in when it happens are about to tell you something your doctor has probably never had the time to walk through with you. Let's start with what's actually happening, because once you understand the real mechanism, the "it's your circulation" explanation falls apart almost immediately. If reduced blood flow were truly the cause of your foot going numb while sitting, you would expect your foot to also look pale, feel cold to the touch, and the numbness would build very slowly and unevenly. That is what circulation problems actually look like. What actually happens when you sit for a while and your foot goes numb is faster, more uniform, and very specifically reversible the moment you change position, and that pattern is the signature of nerve compression, not blood flow. Here is the mechanism. Every nerve in your body, including the ones running down your leg into your foot, depends on a continuous flow of nutrients and signaling proteins moving along the length of the nerve fiber itself, a process called axoplasmic flow. When a nerve is compressed even mildly, even briefly, that flow is disrupted at the point of pressure. The nerve fibers downstream of that pressure point begin to misfire or go quiet. That's the numbness. The moment the pressure releases, flow resumes, and normal sensation returns, usually within a minute or two, sometimes with that pins and needles feeling as the nerve fibers come back online. This is not circulation. This is a nerve being pinched, and your foot temporarily losing the signal because of it. Before I go any further, I want to be clear about when this kind of numbness is something to simply manage, and when it's something to have looked at promptly. The pattern we're discussing today, numbness that comes on gradually after sitting and resolves fully within a minute or two of moving, is, in the overwhelming majority of cases, harmless and positional. But if you ever experience numbness that doesn't fully resolve after standing and moving for several minutes, weakness that makes it hard to lift the front of your foot, what's called foot drop, or any numbness or weakness affecting both legs at the same time, please don't wait this out. That combination deserves a prompt medical evaluation. not a wait-and-see approach. What I'm describing for the rest of this video is the common positional pattern. Keep that distinction in mind as we go. And there are two very different places this ordinary compression tends to happen. The first one is exactly what was happening to Eleanor, and it's the one most directly caused by how you're sitting, right at the moment you're sitting that way. Just below the outside of your knee, a nerve called the common peroneal nerve wraps around a small bony prominence called the fibular head close enough to the surface that you can sometimes feel it through the skin. This positioning, which is necessary for how the nerve reaches your lower leg and foot, also makes it one of the most vulnerable nerves in the entire body to compression from the outside. When you cross your legs, particularly knee over knee, with the top leg's outer knee resting against the bottom leg's thigh, you are placing sustained direct pressure exactly on that point. Clinical case reports describe this exact scenario producing numbness, tingling, and in more severe or prolonged cases, even temporary foot drop, from nothing more than an ordinary sitting position held for an extended period. One published case described a healthy adult who developed numbness and a temporary inability to lift the front of the foot after sitting cross-legged on a hard surface for 2 to 3 hours, fully resolved, with rest and without any surgical intervention, once the position was simply discontinued. That kind of full, severe, but temporary symptom is uncommon. Most people experience a much milder version that resolves within minutes every time they sit this way. This is overwhelmingly a position-related, mechanical issue, and it overwhelmingly resolves the moment the position changes. The numbness from peroneal nerve compression at the knee is classically confined to the top of your foot and the outer part of your lower leg. It does not typically travel up into your thigh, hip, or lower back. For Eleanor, that was the entire pattern. The numbness lived in her foot and the outside of her lower leg. Nowhere else. And it always followed the same crossed leg position, every time. The second cause is the one I most want you to understand clearly today because it can look almost identical to the first one while sitting in a chair, but it points to something happening in a completely different part of your body, and it deserves a different conversation with your doctor. Spinal stenosis is a narrowing of the spaces within your spinal canal, most commonly in the lower back, that puts pressure on the nerve roots before they ever reach your leg. It is extremely common with age. Degenerative changes consistent with spinal stenosis affect up to 95% of people by age 50, though only a portion of those people develop noticeable symptoms. Here is the detail that distinguishes it clearly from a simple crossed leg habit, and it is one of the more counterintuitive things in this entire video. Spinal stenosis symptoms classically improve when you sit and worsen when you stand or walk for any length of time, because sitting, and particularly leaning slightly forward, opens up the narrowed spinal canal and temporarily relieves pressure on the nerve roots. Standing and walking, especially walking downhill, narrow that space further and tend to bring symptoms on. So if your numbness genuinely seems to follow that pattern better while seated, worse on your feet, particularly worse on a walk sitting itself, is unlikely to be the direct cause. The numbness you notice while seated may actually be a baseline level of nerve irritation from the spine that simply becomes more noticeable once the distraction of standing and moving is removed. Or it may emerge specifically as you shift in the chair in ways that further narrow that already tight space. The geography of the numbness is the other major clue. Spinal stenosis-related numbness tends to radiate starting in the lower back or buttock and traveling down the back or side of the leg into the foot, often affecting a wider strip of the leg rather than being confined to the top of the foot alone. It can also appear on both legs, or move between legs, rather than reliably showing up only on the side you happen to cross. And here is the piece almost nobody explains, because it sits at the intersection of two different medical specialties that rarely talk to each other about the same patient. Sometimes it isn't one cause, it's both happening at the same time, in the same leg, quietly amplifying each other. It's called double crush syndrome. And the easiest way to understand it is to picture a garden hose. Imagine that hose has one light kink in it, partway along its length. Water still flows through reduced, but enough that you'd probably never notice from the other end. Now imagine someone steps lightly on that same hose, just once, a little further down. On its own, that light step wouldn't slow the water meaningfully at all. But because the hose was already partly kinked upstream, that second light pressure point is enough to choke the flow down to a trickle. That is exactly what happens to a nerve with double crush syndrome. A mild compression at the spine, the kind nearly everyone develops to some degree with age, reduces that steady axoplasmic flow we talked about earlier, the nerve's version of water through the hose. On its own, it's often mild enough to produce no noticeable symptom at all. But that same nerve, now already running with less reserve, travels down to your knee already compromised. A second separate compression there from crossed legs, from a particular chair, from how you sit, doesn't need to be severe to finally choke the signal down far enough to notice. It's no longer pressing on a healthy hose. It's pressing on one that was already partly kinked. This is one reason some people develop noticeable foot numbness in their 60s and 70s that they never experienced from the exact same sitting habits in their 40s, not because the habit changed, but because age-related changes in the spine had quietly created that first kink in the hose, the second pressure point, the one from sitting, was now finally able to exploit. I think of a patient I'll call Walter when I explain this one. He'd had a knee-level nerve release procedure years earlier for exactly the kind of compression Eleanor had, and it had only partly helped. His numbness improved, but never fully went away. And for years, that was simply chalked up to some people just don't respond as well. When his case was eventually reviewed alongside imaging of his lower spine, a second, milder compression point was found there too, one that had likely been present the whole time, quietly limiting how much the knee procedure alone could ever achieve. A recent case series specifically studying this exact combination, lower spine nerve root compression together with peroneal nerve compression at the knee, found that addressing both compression points, rather than just one, produced meaningfully better outcomes than treating either alone. Patients who had only the knee-level compression addressed when a spinal component was also present often found their improvement in complete Walter's pattern. Exactly. So here's what I want you to actually do with all of this. Not a treatment, a way of listening to your own body that most people have never been shown. First, notice your position, the way Eleanor eventually did. If your numbness reliably follows crossed legs, specifically, and resolves quickly and completely once you uncross and shift that pattern point strongly toward peroneal nerve compression at the knee. The fix for many people is simply changing the habit, sitting with both feet flat on the floor or crossing at the ankle rather than the knee, and changing position every 20 to 30 minutes during long periods of sitting. Second, notice the geography. Numbness confined to the top of your foot and the outer lower leg points toward the knee, the way it did for Eleanor. Numbness that starts higher in the buttock or lower back and travels down the back or side of the leg, especially if it appears on both sides or moves between legs, points toward the spine. Third, notice the pattern across your whole day, not just the chair. If your leg or back genuinely feels better sitting and worse walking, or standing, particularly walking downhill, that is the specific pattern associated with spinal stenosis, and it is worth describing to your doctor in exactly those words, because that phrase carries real diagnostic weight. And if you notice elements of both a numbness that seems worse than a simple cross-leg habit should explain, or one that, like Walter's, never fully resolved even after one cause was already treated, mention double crush syndrome by name to your doctor. It is not an obscure or fringe idea. It is a recognized clinical phenomenon. And naming it directly is often what prompts a clinician to look at both the spine and the knee, rather than just the one that seems most obvious. For Eleanor, the answer turned out to be simple, because there was no second compression site working against her, no kink further up the hose. She changed how she sat feet flat, or crossed at the ankle instead of the knee, and within a few weeks, the numbness that had followed her for years had essentially stopped. 3 things to take from today. 1. Numbness in a chair is almost always a nerve being compressed, not blood flow being cut off. The speed and completeness of the recovery once you move is the signature of a nerve issue, not a circulation issue, and full rapid recovery after standing is the pattern to expect from the common, harmless version of this. 2. Where the numbness lives on your leg, and what makes it better or worse sitting versus standing tells you whether the likely source is at your knee, at your spine, or potentially both at once. 3. If a simple change in how you sit doesn't fully resolve it, double crush syndrome is a real and worth naming possibility, and naming it is often the thing that finally gets the full picture looked at, rather than just the one piece that seemed obvious. You were told it was circulation. It almost certainly wasn't. And now, the next time your foot goes quiet in that chair, you'll know exactly what question to ask it and exactly which doctor's appointment that answer belongs in. Drop a comment and tell me, when your foot goes numb in a chair, does it stay confined to your foot and lower leg? Or does it travel further up into your thigh, hip, or lower back? That single detail tells me a great deal, and I read every comment. If someone you know has been told for years that their numb foot is just circulation, please share this with them. There's a real chance the actual explanation has never been on the table. If there's a leg or nerve symptom you've experienced that hasn't been covered yet on this channel, tell me in the comments. It genuinely shapes what gets made next. Subscribe, and thank you for being here.